Okay, I think we have started. I'm not used to this two screens approach, but can everybody just give me a thumbs up if you can hear me?
Yep.
Who has joined the session? Um, I've got a couple of thumbs up. Perfect. Okay, excellent. Thank you so much, everybody, for joining this session. So this is really part of Dementia Action Week for NaDCAS. We've done one webinar this week. This is the second webinar that's more a kind of conversation with rather than me and the team talking about best practice guidelines. And the focus we really wanted to develop over this session, which is an hour, is strengthening specialist dementia care, particularly within care homes. And I'm pleased to say that we've got some really great people on the panel who can outline their experience of what good dementia care looks like within their own remit. And how I want to run the session. I've just got this title page just to give everybody an outline about what we're doing. But I will end the screen sharing just because I want to, well, one, so I can see everyone rather than just staring at a PowerPoint slide, but also so the panel can kind of step in during the conversation that we've got. What I'm going to do to start with, if it's okay with everybody, is I'll introduce our panel for today. So my name's Sam Dondi-Smith. I'm an occupational therapist and I work with NaDCAS. So my specialist interest really is around quality of life for people living with dementia in care, specifically focusing on people who are living with more advanced dementia. And my professional interests in terms of applying dementia care practice is is giving providers clear kind of underpin and clear strategies for developing their practice. So that's a little bit about me. I'm going to just stop sharing the screen so you can see everybody. And so, Richard, if you don't mind just introducing yourself briefly, and then we'll come on to your piece after everybody's done their intros.
So, yes, my name is Richard Ayres. I'm a social care advisor to Care England. I do quite a lot of work within the dementia space across Care England. Professor Martin Green is our CEO, and we try to replicate his voice across the organisation, social care, to speak to government bodies, both local, national, the CQC, the NHS, or anyone who interacts with our services to really help explain from a care provider's perspective how your wishes and feelings sort of manifest and how we need to kind of represent your voice, certainly in the space of dementia.
Great. Thank you, Richard. And Sarah, if you wouldn't mind just giving a brief introduction to yourself. So Sarah's one of the directors from CCAF.
I am. So yeah, good afternoon, everyone. My name's Sarah. I'm one of the directors at CCAF, which is the Care Consultant Accreditation Framework. So what we stand for is ensuring that we're supporting that building trust back into care, that care providers are working with care consultants that absolutely can do what they say they can do. So their expertise match what care providers are looking for.
Thanks, Sarah. And I'd also like to introduce Vivian Stead, who's head of recreational wellbeing at NaDCAS Care Group. So hopefully Viv will be giving some great insight into how you could be applying principles of excellent dementia care within the care homes.
You've introduced me, Sam.
Sorry. You're much better than I am.
Well, I'm Viv Stead. I've been working for NaDCAS Care Homes for 9 years. I'm the head of recreational wellbeing. My passion is for looking after or working with people living with dementia. My mum has recently got into a care home, so I can see it from the other side as well. and I've been working with Sam for nearly 9 years. We've known each other for a long time. Go back to something called Interactive Me, which was wonderful at the time. And we've had 4 homes that have gone through the dementia accreditation, and it's been really fabulous for us.
Thanks, Viv. So the next part of this session is just some background really from Richard of Care England, just a little bit about the kind of state of play, I guess, in the dementia care space, particularly in care homes, and then what we'll do, we'll open up to the panel, a bit of a discussion around best practice guidelines and what actually good dementia care looks like. And hopefully, the way I would always look at these kind of these discussions or these kind of events is that the people that are on the call will actually leave with something where they can develop their practice. After all, it's Dementia Action Week. It means you've got to take a 1 or 2 nuggets of information that you get today that you can actually go back to your setting and make some positive changes for your teams and for the people that you're supporting. But over to Richard for now.
Thank you very much. Yeah, I'm really pleased to be talking today as part of sort of NaDCAS, CCAF, and NaDCAS sort of care homes. It's a real honour and a privilege to be speaking to people about dementia today. And I'm not a dementia expert, but we work quite hard in this area to try and do what we can, working with informed, educated, qualified people to help really understand what we can suggest as sort of best practice and good guidance for care providers. So I think, you know, today is hopefully, as Sam said, going to be quite practical so people can take some things away with them, but it's not about adding really another abstract sort of framework to the provider shelves. We see an awful lot of frameworks out there, a lot of training packages, a lot of support for care providers, and it's not necessarily about trying to sell the concept of that. It's really about the conversation about how you look into kind of best practice. And I was on a call earlier today. We were talking around continence products, and the word person-centered care came up. And I take a slight issue with that because people use it as a very bland, vanilla, generic statement. But it really is about being very much focused on individuals and individual needs. And when you look through certain dimensions, when you certainly look at dementia, person-centered care, well, what does that actually mean? Because actually, if someone's got a cognitive impairment, you know, how does that kind of relate, because they can't necessarily engage, and how do you know that what you're doing is person-centered for them? That's a slight aside. I just came up today and we had quite a good, long, healthy debate on it. But from Caring's perspective, you know, dementia care is incredibly important. It's something now that we see as the norm rather than the exception. It's across most services, whether people have a diagnosis of dementia or not. But we do see it across, you know, nursing, supported living, extra care, right across home care. And people are living with more and more complex needs, more advanced frailty, and more coexisting conditions and comorbidities. Dementia alone is not usually a single diagnosis, it's lots of other things. And at the same time, providers are doing so much to care for people within their environments, but they are struggling with the backdrop of workforce capacity, recruitment, retention, funding, commissioning hospital discharge processes, admissions to hospital, rising acuity, family expectations, the regulatory expectations, the department's policies. And we've had Casey make mention to dementia within the strategy, so there's going to be more informed focus on dementia. So when we talk about strengthening dementia care, we kind of really do need to be honest, because we can't simply say to providers, you need to do more, you need to train more, you need more evidence, you need to record more, without recognising the environment in which care providers are working in. It's an incredibly challenging area at the moment to be a care provider, let alone a care provider who wants to excel in dementia care. So, you know, many services that we work with are already trying to do the right thing, and some of them are doing absolutely amazing things. And many staff are really deeply committed, and managers know exactly the type of care that needs to be provided. But the challenge is often not the absence of that good intent, but the challenge is consistency. And that's probably one of the important points, I think, for today, that in dementia care, consistency for an individual is possibly everything in most cases. It's the difference between the person being understood and the person being managed. And this is where the person-centered kind of point comes in. Are we managing people because that's the way that we're structured and resourced, or are we actually meeting their needs? Another area that used to come up and used to sort of get my hackles up was, challenging behaviour. We call it now behaviours that challenge, and I'm seeing more and more people talk about that as unmet need. And that's, I think, a much clearer way for me to be less offended by such a term, because actually, if we are meeting people's needs, then it's far less likely that we would see some form of behaviour that would lead us to conclude that it was challenging. The gap between good and bad providers is not always easy to see on the surface. Care plans may say that someone becomes distressed at certain times of the day, and they need processes, they need time to kind of process information, certain words or tones might make them anxious. And I think that's very much about how we kind of look at dementia. And this is where we come into the person-centered point again, about really understanding the individual and what they need. And it really is a sort of a generic term, but it's where I think dementia services can become quite fragile, because there are lots of practical frameworks out there, but a framework is not necessarily suited to meeting someone's individual needs. And this is why I think the accreditation side of things is great, because it does look slightly beyond that. It's not just a tick box saying, okay, we've implemented a training course, very much like Oliver McGowan. I don't think you can learn about learning disability and autism in an 8-hour training course. With all due respect, I think it takes far more than that to really understand the full spectrum. We see dementia as a spectrum. It's not a single isolated homogenous thing. It's something that manifests in very, very different ways for everybody differently. And I think that's one of the important points that we as Care England really want to kind of take on board. NaDCAS, really describes its role as recognising excellence in dementia care through evidence-based framework informed by current best practice research and professional experience. And that's exactly what we believe is person-centered care, because it's really targeting those individuals. And from the CCAF perspective, it really does help to bring a different perspective about how a third party might come in and look at our work, look at what we're doing, looking at how we're doing it, why we're doing it, and are we actually working in a way that's right for the individuals, or is it the way that which we're working because it suits the way that we're structured as an organisation? So that's the balance that we need to really understand, on top of all those other challenges across the sector that we've talked about. I don't think documentation really improves dementia itself. Documentation absolutely matters, but it's how we share the knowledge, the evidence, and the decisions that come through. And there's some really great inspirational stuff that we're talking about at the moment around how when we do the initial intake for someone, we do that pre-admission assessment, and we're not just using dementia as a tick box. We're actually starting to understand, well, what is mum or dad like, what are they like now, what do they like, what do they dislike, what triggers them, what makes them happy, what makes them smile. Actually, where are they at this point in time? Are they living in present day, or are they attuned to a different time, date, or place? What music did they like then? What did they like to wear then? What colours did they like? What were their interests? So really starting to kind of get that second and third level of detail to understand the person, because when we really understand that person, we can try and provide that compassionate, caring support in a way in which they need to receive it for where they are at their moment in time. There's also lots of very generic terms. Again, I talked about behaviours that challenge behaviour, walking with purpose, calling out, disorientation. These are all very generic terms again, and I think it's really helpful to start understanding what they mean to individuals on an individual basis. I think we've got quite used to using generic terms. I think that can be really dangerous and really destructive. And when we look at placing safeguardings, another point in Casey's comment around safeguardings is that we need to really make sure that we're not using these generic kind of bland terms. We need to be describing and understanding what's underneath it, so we really get to those core needs. What happens when someone's distressed? Really making sure teams understand that person's history. Their history is so important. Their level of loneliness, their sensory needs, and their fears, because they all drive behaviours. And these are the things that we might not be meeting as individuals. But again, we do need to look at things like medication, constipation, infection, dehydration, sensory overload, unmet emotional needs. These are all factors that trigger in people that, again, we need to look at them in a multifaceted way to really understand what's going on for individuals. So, first getting to really know the person, not just their diagnosis, understanding their biographies, their preferences, their relationships, routines, triggers, strengths, their fears, really helps to understand the individual more. And then understanding that all behaviour is a form of communication. Distress is not simply something to stop, it's something that we need to understand because there's a need behind it. And again, it's very easy for us as organisations that are directly providing care to talk about this, but these are the things that keep coming up to us, the things that providers tell us and consultants tell us, and the experiences we see. And we see some amazing providers who are really looking at this level of granularity and really transforming the way they deliver care and doing things in a way that might on paper make absolutely no sense. And there's a wonderful service recently, Martin talks about a great experience where he went to a site and had a lovely chat with a gentleman outside who was cleaning cars. And this gentleman used to work in a car showroom. And he said, these cars, they keep coming, they keep going. As soon as one comes in, I clean it and it's gone. And this was an elderly gentleman who was cleaning cars physically. And he really believed where he was. And some people may be uncomfortable with that, but he was living his best life. He was thoroughly enjoying every moment of his life. And inside the service was a wood shop with people using tools and chisels and saws. And again, risk assessing and thinking, oh, we can't do that. These people were living their best lives. They were doing arts and crafts and things that really worked for them. So thinking differently about things is kind of where Martin's really kind of driving us to not look at the norms and the standards all the time. I could probably keep going on, but I just will sort of stop there. But that's kind of where we see as, what we're learning about dementia, what we're seeing that's changing. We know.
I think.
Sorry, carry on.
I think it's great. Thank you, Richard. It's really, really helpful. I think the core points that you've stated there, which I totally would mirror, is around knowing the person, which is much easier said than done sometimes, because often I know when I've spoken to providers, people might have moved from a hospital into a care home. And the provider actually knows very little about that person. So something like understanding their background and their interests and preferences can take time, but it is something that is so important, particularly if somebody's dementia does progress and they're becoming distressed. If you understand that person's background, and some of their life story, then it can help inform you how to support them when they're living with distress. So knowing the person, really important point. I definitely reinforce that. And the power of language is something that is without a doubt a very, very important area within how our home creates the culture that is set in the home, and understanding lived experience. Can I bring in Viv, if that's all right with you, Viv? Because you're kind of on the ground in the homes, and you're seeing day to day the teams delivering care for people living with dementia. Can I ask if have you got any moments or any kind of examples, or when you felt this is what I feel, I believe good dementia care to be like? This is a moment of fantastic practice that makes your heart sing.
I'm very much on the ground, and I'm in care homes all the time, really, with the recreational wellbeing staff. So I'm with the residents all the time as well, which is lovely for me. But I can't express, even more than Richard is saying, that life story and understanding a person is so important. I'm ashamed to say that sometimes you've been into our homes and said, tell me about this person, and we can reel off everything that is medically wrong with that person, but what makes their heart sing, what makes them tick, what makes them tap their feet, what makes them happy and what makes them sad, we couldn't tell you. So you know, it's really important for me. And I was on your webinar yesterday, or the day before. Was it yesterday or the day before? And my three things were, my three challenges to all of our care homes was to read 5 people's life stories and get to know those 5 people, because it's so important.
Yeah.
And I think that, but it's sometimes it's very difficult to get a person's life history, because and my staff say, you know, we give them the piece of paper and they just don't give them a piece of paper. Tell them how important it is. Tell them we need to know about everything there is to know about your mum or your dad or your aunt or your uncle, because the things there, that's how we can look after them as a person. We'll look after their illnesses and everything as a given, because everybody knows about all of that stuff. It's the soft stuff that we find difficult to grasp, and it's for me it's the most important.
Yeah, that soft stuff, as you say, it often comes secondary to the medical, but when you see it put into practice, that's when, and I reflect and totally agree with you. When you see that put in practice, when I love going to into a home, and a team member introduces one of the residents to me, and explains a little bit about their interests and their preferences, and that allows me suddenly to get to know them as a person. And yes, the dementia is part of that person, and they may have the cognitive impact of the dementia, which is affect them in a variety of different ways.
But they're still proud of what they've done and what they've achieved, Sam.
Yeah, absolutely. So would you say then? Would you say that good dementia care comes in those moments? Is that where you see it? Is it something you can kind of put your finger on, or is it something that you feel, or you see, or you?
I think I feel it, really. I think it's difficult to sort of like pinpoint one particular thing, but I think it's just understanding the person,
Yeah.
and knowing the person, and you know, treating them as a person. That it's not an illness. It's not, you know, it's they're people. They're just like you and I.
Yeah. Why do you think then that for some providers it can be difficult to get to that place where they do know them as people? Like what is it about and Richard mentioned it already, particularly around kind of language and understanding and culture. But I just wonder whether you've got
I think
any
it is a
kind of thoughts
cultural
on.
thing as well. I think it's a culture change, really. If you're gonna get really into good dementia care, you need to look at every part of your service.
Yeah.
So as you do when you do an observation, Sam, which has taught me an incredible lot. But it's, you know, it's not the one thing, but I do think it's the person rather than, you know, anything else.
Know the person. Yeah.
Yeah.
Sarah, can I bring you in?
Yeah,
I just wonder whether you've got any thoughts on what I know your kind of day to day is not on the kind of on the floor, as it were, within care homes, but I just wonder whether you've got a sense when you're thinking about dementia and dementia care, and maybe for the people that you do know who are living with dementia, what you feel like good dementia care does look like from a provider's point of view.
I think actually it's probably easier said than done, isn't it? Because, you know, what everybody needs is time, and we know that within for care providers, you know, there's so many constraints and financial constraints, and we're bringing in agency staff, and I've seen so many care plans out there that you know, for somebody coming in for an agency to sit there and just read maybe 2 lines, and this is their dementia care, this is what makes them happy. You know, it doesn't really give a true reflection. And I think for us, you know, it would be our consultants being able to go in there and absolutely supporting care providers with, you know, yes, we understand that time is an issue, but actually, you know, that to take this time and ensure that, you know, when you haven't got your usual staff in, that we're still able to give the right level of support and care and understand, you know, the people that you're working with. You know, we look at environmental design, so you might have a home that will absolutely implement, you know, a system throughout the whole of the home, but that one size doesn't fit all. So you may have 100 beds and 50 of the beds have got dementia patients, but you know, you can't change all the toilet seats to yellow because that's what you've been advised to do. That's not going to fit with everyone. We need to make sure, you know, that it feels like home. They live in constant confusion. So yeah, for us, it's about our consultants spending that time, not just with the managers, with the frontline teams, and really supporting them, and helping them embed, you know, real positive change, really looking at focused project plans, how they're going to keep it live, continuous improvement. Yeah, I think that's what's important for us.
Yeah, I think it's a good point on the word home. I think it's something that I would always drill down as much as I can, what that means for different people. I think you can think you can think from an environmental, like you say, Sarah, a point of view that you can make an environment feel homely for people, and that can be, you know, from bringing items in that are meaningful to that person and either dressing their room or potentially, you know, I've seen it in some homes where they've got people's own pictures and possessions or copies of pictures in the living spaces, and suddenly that transforms an environment from that kind of that clinical more to that homely feel. The other thing, I think something that I've learned definitely from working with David Sheard is understanding the feeling of being at home inside yourself as well. So that feeling of being at home inside yourself, it can be impacted by your environment, but it can be also impacted by the people that are supporting you, and how they make you feel. And I think Viv's already mentioned around culture, which is a culture of a home that you can feel when you walk in, and it can be changed, but it takes a long time to change a culture of a home. I Unless, it doesn't always take a long time, unless suddenly there's an injection of kind of energy and maybe a change of leadership. Personally, I always feel like the person that is leading, the is at the helm of the ship, is usually the registered manager. They are the person that shapes that culture. They are they're the instigators of change. They're the people that can nurture the team to create that feeling of people feeling at home inside themselves. The other point that you made, which I thought was really important, I can't remember who brought it up now, forgive me, was around positive risk within care homes and within dementia care. And I wonder whether Richard, whether you've got any thoughts on positive risk, or whether kind of Care England are kind of, you know, behind the promotion of positive or therapeutic risk in dementia care, and how, particularly, I know when I've worked with homes who sometimes they're up against it with their CQC inspector, who see the risk quite differently, and potentially can put up barriers to enabling people to live meaningful activities, meaningful lives within the culture of a care home. I just wonder whether you've got any thoughts on that one, Richard.
Well, I've seen it brought to life in a couple of occasions. I went to a fantastic service in Cambridge, and we went out. They do a lot of physical work with people with dementia, and most people in the home have got dementia. And we went out with the staff there, and the residents, and we did a 10,000 step walk through a very bumpy forest park with tree roots and bridges and rivers and fields and really uneven ground and uneven car parks. And it was pretty much done one-to-one, although there were a couple of individuals there who like to kind of march off and lead. But on paper, you would not have taken these people, and some of them were physically impaired as well, with cognitive impairments as well. You would not have taken them into that environment. And then when we got back, one of the gentlemen who was kind of marching off, he was telling us about the bike rides, and he's got dementia, and he knows he's got dementia, so he isn't completely in a state where he doesn't know that he's got dementia, but he likes to go on bike rides, and he's got his racing bike, and he went out on quite long bike rides, and he fell off into a ditch a little while ago, and he was brought back to the home by someone very nice locally, and my thoughts were, if you look at this on paper, you'd be saying, well, safeguarding risks, stop doing it. But they were actively promoting this kind of support and engagement. And when you saw these residents coming back, they came straight back from a 10,000 step walk and went into a dance class, which we also had to do as well, which was phenomenal. But we were seeing people really transitioning. But the emotion in the home and the feeling in the home was that, yes, there are risks involved here and there are concerns, and you do need to make sure things are done safely. But do you want to just keep people in a lounge where you're putting in someone to come and do some dancing, where people are regressing and degenerating very slowly, they're deconditioning very, very quickly, and they're not really participating in activities and tasks, but you've ticked a box to say you've got a task and activity. So we are seeing it brought to life. There was another great example of a service over in the West Country slightly, and they wanted a pond in their garden, and the CQC saying, no, you can't have a pond. And they were, we're having a pond, and we're having a fountain, we're having a pond. They just had to build up to a level where it was safe to do so. And even on paper, the CQC is saying you can't have it. They came and they talked about the service. They explained it. They showed the CQC, and the CQC were then happy with it. But on paper, you say you want a pond in there, they'd say no, you don't do it. And you kind of have to push and challenge a little bit. Yes, you've got to make things safe, but people need to live in environments that are real to them. We don't want everywhere having a lounge with library book pictures on wallpaper, because just because someone's got dementia, it doesn't mean that they don't know that a picture on a wall of a book is not an actual book. But yet we see loads of corridors designed to be outside streets, outside someone's front door. But someone isn't stupid. When someone's being showered with dementia, and they might be 80, living at the age of a 15-year-old, they still know that when they're stripped naked, that's wrong and they lose dignity. So it's about doing things differently and understanding what risks are involved and how you can sort of navigate some of those risks in a safe way. And yeah, just making positive risk assessments of why people can do it, not starting from no, we can't, starting from how are we going to do this. Another one was great tricycles. There's a dementia cycling club where these people going out and they're on 3-wheel tricycles, and they go on these really long cycles, and they've just got one-to-one support with them driving on a bike next to them, and they're going on public pathways, no problem whatsoever.
I think so sometimes it's more detrimental to somebody to not allow them to take a risk than it is to allow them to take the risk, because it's, if you stop people doing things and they really want to do it because of the risk factors, it's detrimental to the person anyway. And I think that's, I've seen, I'll take it to a different example. We've seen places where we're trying to change the environment to more homely, and people will say they live with dementia, they'll eat it. No, they won't. They won't eat it. And if they do, then we'll do everything we can to prevent them, or to to help them. But you can't live in and I think sometimes it's the clinical people who are more risk averse to things as well.
How do you kind of shape or change their viewpoint if you've got somebody, if you've got a team member that is, or even a manager that is very risk averse or fearful of those kind of changes being implemented? How could you approach that, do you think? What would you do, Viv?
I think do it first of all, measure it, observe. I think observations, and that's another thing that I put on my list yesterday to do in Dementia Action Week, is to get everybody to observe their lounges, their dining areas, just observe the care that's going on, the care that's happening, and take your your professional hat off and just become a person looking at people and how we treat people.
Yeah, I agree. The word I always use with any manager or staff member who does seem particularly fearful about these kind of changes is try.
Yeah.
It's just try. And like you say, Viv, and this can be around most commonly seen is around opening the doors to the outside space. There's a lot of fear around having doors to outside spaces unlocked, and then also around supporting people to remain as independent as possible particularly when making food or making a hot drink, and being supported by the team to do that. And like I say, the word I would always use is try, and just as you said, Viv, is observe. So we're not saying just go for it and hope for the best and it will be fine. It's observe what happens, and 9 times out of 10, and I'll speak for a good friend of mine, Stuart Wright, who's with Brunel Care. I never forget him telling me they've got services down the southwest that they put in place hot water kind of kettles that people could access quite freely. And he said the only people that got burnt over a kind of or got scolded over a 5-year period were a couple of staff members because they were rushing. Nobody, that was living in that community had, were scolded or injured. So it's about trying and about trying to get out of that. I would kind of position it as a kind of an old-fashioned headspace of, just as you've said, Viv, kind of quite clinical, quite quite almost like a kind of a hospital style service. You should be thinking about how do we support people to live as independently as possible in their own home. And for us at NaDCAS, we're all about kind of sharing that best practice, and one of the things that we want to be doing this year is connecting up homes. We've done it with a couple of homes, connecting up homes that are doing really, really well at some of these areas, in some of these areas, particularly positive risk, and connecting the managers up with other homes that have got, and it's not through, it's not their own fault, but they've got a bit more of a risk aversion and a bit more of a concern around positive risk, because it is something that I think is changing slowly, but it's often down to individuals to try and interpret how beneficial positive risk can be for people. And just as you said, Viv, what is safe? Is safe sat in a chair, asleep, and with a cup of tea every couple of hours, or is safe about or that feeling of safety is the feeling of home, I would say.
I think looking at activities, which is what I do sort of like most of the time,
Yeah.
is I see people playing with pool noodles and balls and stuff like that. And I'm at a home on Canvey Island at the minute, and we've had about 7 or 8 elderly ladies playing football today. And sometimes people think, oh my gosh, it's too much for them and everything. They had a ball, absolute ball. Let them enjoy themselves. And that's, sometimes people can say, oh, you need to have a Zimmer frame with it. Well, yes, you do. Obviously, it has to be safe and everything, but let them live. That's the thing.
Yeah.
Sam, I wonder from a NaDCAS perspective as well, just for me, I kind of wonder about staff confidence and their understanding. So just from your point of view, do we think that's a massive barrier? Because it's all very well completing e-learning, and I've done 5 modules in this now, so I'm a dementia expert. So is that a big problem that you're finding?
Yeah, and I think I do think it comes back to the leadership team within a home, being out on the floor and provide, in a sense, kind of providing permission that this kind of approach is okay. I think you're on the money there, Sarah, that some staff, some team members are not confident and they're not quite sure whether this is okay or not okay. And I think where it works really well in homes is where there's a manager or a management team, that are out in the living spaces or within the dining settings, that are leading by example, and then suddenly the teams see this kind of thing happen and go, oh, this is how we do it, or this is what care is all about. But it does take leadership. It does take that leading by example and the mirroring, and sometimes it can, within, if a manager is, say, doing some ad hoc training or teaching new team members, it should be about them delivering those expectations of what good care is, what safety is, and how and what the home's culture is. I think it always has to come from that leadership position. And if the leadership team are less hands-on and they're more focused on, and less busy out actually on the floor, as it were, then I do see that impacting how the confidence of the teams, and sometimes their uncertainty of knowing what's okay and what's not okay. And I'm sure it's human nature that, we would only, um, we'd only have an understanding of what risk is from what we've already observed other people doing. I think that's fairly normal human nature. Whereas if management teams are leading by example, then there's there's an understanding from the team members' point of view, particularly new team members, that this is how we deliver it here. This is what we do here. And is one of the points I forgot to mention that leads on to this, which is really important, I think, is the induction. So the induction process of new team members. Within the NaDCAS framework, there is a section called vision, values, and leadership, and part of that is around understanding, one, how you're recruiting people, which ideally should be based on some emotional intelligence as well as their understanding of what good care looks like, but also the induction process of, how do we as an organization induct this new person, how do we nurture this new person, and show them what our culture is. And I was at the home care show yesterday, and there was a really great presentation on. It's quite separate from this, but it's got a relationship to it. It was a really great piece on developing an organization, and the core part, and I think this, you can boil this down into separate homes, because every home has its own culture, is the manager sets the culture, but the team follow by example, and new team members particularly, they follow the induction, because that's what they're shown, that's what the expectation is. So if that induction is, and I've been in services where this is the case, if that induction is 2 shadow shifts and you're off to the races, off you go, then it can be, not for want of that, not for, it's not the new team members fault in a sense. It can be the kind of the blind leading the blind, in that some team members, if they're only got a couple of shifts where they're shadowing someone, then they're only following what they're being told by the person that they're shadowing. Whereas if you've got an induction that is more comprehensive, that outlines, you know, the vision, the values, the expectations. I particularly like it when you see providers that are the care team members actually have some time with the activities and the well-being team members, because I think that can induct them into the expectations of the culture of this home is around engagement, and we want you to be engaging with the people that are living here. So the induction process is very, very varied and very, very different across providers. But I guess the thing that I want to reinforce is that it's so critical that that is your point in time, that is your moment for supporting that new team member to be delivering great care, but it's your opportunity to nurture them and shape them as individuals, and tell them what your values, what your vision, what your kind of what your passions are, and you know, it gets them hopefully motivated to do a fantastic job. Anybody else got any opinions on inductions? I just wonder if there's if anybody's inductions of new team members.
Just I don't have that experience. Maybe let Viv come in on that, but I just we've got such high churn and turnover within staffing that it's going to be an ongoing challenge, that you have to have a way of managing it. We're not going to be able to not do it, but if we always do what we've always done, we'll get what we've always got. And I think we have to kind of look at things differently. And again, and one service we saw recently had people, residents, split into community groups, and they lived within their communities, and there were people who were like them, who they're more likely to identify with and socialise with outside in the real world, or where they would have lived before, but in a safer environment. And you talked about the going outside point. So they live in these units, there's 5 or 6 people there, but they don't have care workers, domestic staff, catering staff. The workers that work with them are the same people who work within that community, and they're dedicated to that community. So it makes it much easier if you're bringing in one new person because someone's left. You're part of a community. And I've never gone into a service before and seen the staff sitting down watching TV with the community. And I was like, well, this is just unheard of. I've never seen it, because I see care staff running around ragged, constantly just working, because there's never a moment. And these, you know, they cook in there, they eat in there, they walk down to their shop within their grounds, and they get their appetito meal when they take up to the unit, and they cook. So they put their coat on because they have to go outside, walk past the pond that I was talking about. They walk past the laundrette where they can drop off their service wash or do the washing themselves. And it's about living in the real world. I think that was where I thought, from a staffing perspective, induction is that it's really tough for staff to do the same thing all the time and know you're doing it for maybe a large number of residents, and you don't know them intimately, and you don't have those relationships. And that's when I think we see a lot of kind of churn. But actually, if you work in a community where these people are more like family, more engaged with them, I think you will see sort of slightly less in terms of the attrition, but people more get to know what you need. And that's when I think you can really focus in on that person-centered kind of model of meeting someone's individual needs. But yeah, I think we've built a model, and we are at risk in certain locations of that being a more institutionalized type model, because we've got the same infrastructure, the same stock, the same way of working, yet the profile of people is changing, and dementia levels are increasing, and people are coming to care far later with more complex needs. But we've got the same model of care that we've always provided. We're trying to make everything else fit around it. And actually, we need to start maybe just thinking a little outside the box on those things.
Yeah, absolutely. No, I agree. Viv, can I ask, so just before we kind of do some closing remarks, and one of the things I want to do, as I said at the start, is for people that are on the call to leave with something that of clear action that they can put into practice. Just with Viv, with your role, are there any specific well-being or activities or that are specific interventions that you've seen that have been really positive for people living with dementia at NaDCAS? Viv, are you still there? I think she's frozen. Oh, maybe she can rejoin. Hang on. Viv, are you still there? No. I'll try and answer the question for Viv, rather than teeing her up with the question. From my experience, there are some really great interventions, really great therapeutic approaches that people can use within their settings. One is cognitive stimulation therapy. Now, this is something that is actually one of the few non-pharmacological approaches within the NICE guidelines to support people living with dementia that are classified broadly as kind of with mild to moderate dementia. This is a therapeutic approach that people can go on a training course, or there are some digital technologies now of CST that providers can be implementing cognitive stimulation therapy within their services. And the evidence base that was put together by UCL and led by Professor Amy Spector was that there is quite strong evidence for CST that it can slow that cognitive decline, that rate of cognitive decline. So please look into cognitive stimulation therapy. The other therapeutic approach, which is more suitable, though not totally suitable, for people living with more advanced dementia, is Namaste therapy. This is something, again, you can go on teams can go on a training session with either Namaste Care International, or I think the University of Worcester deliver some training now on this, and it's about implementing a therapeutic approach particularly for people who are living with more advanced dementia, who may be presenting with distress at times, and again, it's got a really strong evidence base. So there's lots and lots of therapeutic interventions that have a strong evidence base, but those two I particularly wanted to raise. Before we finish, I think Viv's sadly her signal must have gone. I don't think she's been able to join back. I wanted to just ask the panel if there are any practical changes that providers can make. Let's say they something that they can take away today and try and implement that can make some positive change within their care, within their culture, and impact the care that they're delivering. I just wonder if I could just go through with Richard and Sarah, if there's some kind of golden nuggets, if you like, of things that providers could be doing just to make some changes within their settings. Richard, could we start with you? Is that all right?
Yes, we put a couple of papers out recently around with Be Brave Fitness. Bailey Greeton Clark, he's one of the influencers across adult social care. He's the most followed influencer. And he's done some work with us. It's quite a small scale, but it just really talks about physicality, getting people moving, forms of kind of light exercise and movement. That can be armchair, it can be seated, it can be standing. But what we've seen is that actually it completely transforms people who were degenerating and people who were regressing. We see that has really changed their approach, and they're far more engaging, far more open, and far more aware, far more engaged in their roles, less likely to fall because they've retained some of that core strength. So that would be one of them. And the other one would be hearing loss. We know that hearing loss is part of the aging process, but where people have hearing aids, they shouldn't be kept in the bedside drawer. They should be worn. As hard as that is for people, what we do know is that when those hearing aids are not worn, people degenerate far quicker. It elevates the rate at which they decline, they regress. And I think we're about to launch a campaign later this year, which is 4 things you can do. Train staff on how to put them in, train staff on how to clean them, look at earwax removal, and get people wearing them, because we know that really does slow the rate at which people decline with their dementia. So they would be the 2 things I would suggest: movement.
That's great. Thank you, Richard. Can I ask, just on the fitness point, I totally agree with you. with the I've forgive me, I didn't hear the partner that you're working with. Do they?
Fitness.
What was it called again?
Be Great Fitness. I'll drop the
Be,
reports into the chat for you.
yeah, that would be great. Be Great Fitness. Do they advise on a certain amount of exercise or a certain and do they have resources that people can access to kind of promote fitness for their populations?
Well, and actually, one of the papers talks about this is that you have, before you do any fitness, any work with anyone, you have to get to know them first because it's absolutely different for everybody. So getting to know the individual, there's a program that can be tailored for every individual, but it's again that person said of it, get to know the individual and then tailor the program. Look at some of his videos online, you'll see that, I mean, he's doing boxing with 90-year-old ladies, you know, and you would never think, oh, that's a program I'm going to put on for someone, but tapped into what they like, and that's what's working for them, and they're loving it.
Mm. That's great. Thank you. Sarah, have you got any sort of tips that people could take away and you know, just to implement some change, say today and tomorrow and the next few days?
Yeah, I think I was talking to a consultant this week actually, and he was telling me about what in one of the homes that it was in, you know, they were putting everything away. This particular client of theirs, he was into football, loved his football, and but everything was put away. But what they implemented was they looked at the journey from his bedroom to the lounge area, and they put some stop stations in, they put some rummage boxes, and in the rummage boxes, rather than pushing away that memorabilia from his football club, they put it in there, so it just reminded them on. So really looking at that journey, you know, between the bedroom and to the lounge, is one key takeaway. And I think the other thing for me would be maybe a little bit of a challenge to care providers for the leadership team. I know we've spoken about this quite a lot, and not just for a week, but to absolutely you know, make sure that you're sitting in the dining area, eating your lunch in there at the same time as everybody else, because that will really open your eyes and see what's going on. And I know that our consultants, it's the dining area and the lounge that really makes the difference. And I just think if the leadership team are leading that culture, they should be, not just for a week, but I think they should continuously be going in there and setting them bars.
Yeah, it's a good one. Yeah, we you know, we haven't had time to talk even about the dining experience, but I think it's a really good one. If anybody does want a like a dining experience checklist, I know we have that. So if you want a copy, we can send you a copy. Anybody who wants any information that's been discussed in today's session, then just put your email in the chat and we can send those reports. Richard's kindly put them the reports that he mentioned in the chat there. From my point of view, there's quite a few quick wins I would always say for providers who are supporting people living with dementia. We haven't, because it's only an hour today, we haven't had a chance to discuss the environment. But I think environmentally, one of the areas that we see gaps quite often is just around resource, just things out in living spaces. So I guess you could call them resources, or you know, things that people can engage and interact with quite often. And I partly blame, and I know it was 6 years ago, I partly blame COVID for some of this sometimes, is that we go into a living space and there's people are sat around, but there's nothing on the tables, there's nothing on the nothing near them for them to pick up and engage with. And ideally those resources may be ideally those resources should be person focused. You know, they shouldn't just be just a few random fiddle muffs and fidget boards scattered around the place. They should be something that are more personalized to individuals, and even graded and adapted to support their particular levels of cognitive functioning. So just get resources out in living and dining spaces. I'd say that's a really quick win that really helps people engage and sometimes orientate themselves. We talked a little about the homely environment. Viv mentioned it briefly when we were talking about I can't remember which area of practice it was, but the point I wanted to make was around observation. So what we would call qualitative observations, and there's many different tools out there. The most recognizable one is dementia care mapping, but there are other tools that are you don't have to go on training sessions for that are free to use, like the PORT tool, person-centered observation and reflective tool. And the reason why qualitative observations are so powerful is that they allow teams to observe each other, and then there's a reflective practice element to those observations, so that they allow teams to self-develop and understand how other team members are interacting, engaging with people, and the quality of those interactions. So definitely look into qualitative observations. Cognitive stimulations therapy I've already mentioned. The other one, environmentally, I know we're over time. I'll wrap up in a second, but it's a really quick win. Is on your phones you can download a light meter, totally free. There's lots of fantastic evidence from the University of Stirling around the benefits of light. That's natural and unnatural light for people living with dementia in care homes. And you can download a light meter. It's not a kind of professional one, obviously, but you can get it on your phone because your phone does have a light sensor on it. And it tells you the light readings in certain areas. And the golden number is 150 lux. That if you're walking around the living spaces or people's bedrooms and they're not at that kind of level of light, then increase the light, because it will allow people to become more alert, more engaging. Not only the people living in that space, your residents, but also the teams as well. So look into light. It's a really important area of practice, but is actually quite a quick win for providers. Great. We're over time. Thank you everybody for joining us. Thank you, Sarah, for your contribution. Thank you so much, Sarah, and thank you, Richard, from Care England. Thank you very much for your contribution. And Viv, wherever she may be, she seems to have left us. I'm sure it's something to do with the signal within the home that she's there. But thank you all for attending. I do hope, because as I said at the start, it's Dementia Action Week. I hope you've got a golden nugget today that you can take away and you can make some change happen, because that's what this week is all about. So thanks for your time. And if you will be able to access the recording if you want to pass it on to other team members at a later date. So take care. Have a good afternoon. Thank you. Bye.